Good morning, students. I'm Dr. Geetha Siddhapur, Professor, Department of E.N.T, Sri Lakshminarayan Institute of Medical Science, Puducherry. The topic I'll be discussing about today is about Meniere's disease. Coming to the specific learning objectives of today's session. At the end of the session, the student should be able to describe the pathophysiology of Meniere's disease, describe the pathognomonic symptoms of Meniere's disease, list the set of investigations needed to confirm Meniere's disease, describe the possible pure-tone audiometry patterns in Meniere's disease, describe the principles of management of Meniere's disease, and list the indications for intratympanic gentamicin injection in a patient with Meniere's disease. So the Meniere's disease is otherwise called as endolymphatic eye drops. This particular topic is very important. It's a must know topic in the undergraduate curriculum. This question has been frequently asked as a long essay in your theory paper, as well as very frequently asked in your clinical viva examination. So before I proceed with pathophysiology, I would like to highlight about the history. So it was in the year 1861, Prosper Meniere described the classical symptoms of Meniere's disease, and he attributed that these symptoms are mainly because of the pathology in the labyrinth. In the year 1871, Knappen theorized dilatation of membranous labyrinth, and in the year 1938, it was Halpike and Portman who confirmed endolymphatic eye drops via temporal bone histology. In the year 1972, a definite criteria was defined for the Meniere's disease by American Associations of Otorhinolaryngologists, and in the year 1995, again the definition was revised and a protocol was set. So when do you say Meniere's disease? What exactly happens here is there is a triad of episodic vertigo, fluctuating hearing loss, roaring type of tinnitus, and oral pressure or fullness. So these are a classical symptoms which you come across in a patient with Meniere's disease. When do you say that, yes, this could be a possible Meniere's? That is when there is episodic vertigo of Meniere's without documented hearing loss, or when there is sensorineural hearing loss which is fluctuating or fixed, but there is no vertigo as such. Other causes excluded. So when do you say Meniere's disease? Probably it is Meniere's. That is when there is one episode of vertigo at least, audiometrically documented hearing loss on at least one occasion, there is tinnitus or oral fullness in the treated ear, and other causes excluded. So what is definite Meniere's disease? When there are two or more definitive spontaneous episodes of vertigo lasting for 20 minutes or longer, audiologically documented hearing loss on at least one occasion, tinnitus or oral fullness in the treated ear, other causes excluded. So certain Meniere's disease is confirmed only when you do histopathological examination. Now, before I proceed, a brief difference between perilymph and endolymph. So perilymph is the fluid which is present between the bony and the membranous labyrinth. This fluid is similar to extracellular fluid, which is rich in sodium. And if it's unclear if it's an ultrafiltrate or of a CSF or a blood, it drains via venules and middle ear mucosa. Whereas endolymph is within the membranous labyrinth. It fills the vestibular end organs and cochlear duct. It is similar to intracellular fluid, rich in potassium. This is produced by marginal cells in stria vascularis in cochlea and dark cells. Increased in maculae. Endolymph is absorbed by endolymphatic sac. Now coming to the pathophysiology, what exactly happens in Meniere's diseases? When there is increased endolymph, there is rupture of the membranous labyrinth, that is the rhesus membrane. So when the rhesus membrane ruptures, there is mixture of perilymph and endolymph that causes sustained inactivation of hair cells and neurons of vestibular cochlear nerve. That triggers the symptoms wherein you get vertigo, deafness, and tinnitus. Along with this, there is increased sympathetic activity, which causes ischemia of vestibular as well as cochlear end organs, and that causes deafness and tinnitus. So if you can see the first diagram, this is the normal inner ear. The blue line, blue color, what you see is the endolymph. In the second picture, you can see that there is increased endolymph. The vestibule, the saccule, the utricle and the saccule and the cochlear duct, the blue color fluid is increased, as well as the endolymphatic sac is distended. So this is basically what is happening. The pathology is mainly there is collection of endolymph in the membranous labyrinth. This is one of the cross section of the cochlear duct, wherein you can see scala vestibuli, scala media, and scala tympani. So if you see in the first diagram, you can see a normal basilar membrane with outer hair cells, inner hair cells, and there is endolymph within, and you can see the rhesus membrane. In the second picture, you can see there is increased endolymph causing bulging of the rhesus membrane, and if the pressure increases more, there is rupture of rhesus membrane and mixture of endolymph and the perilymph. So what are the theories behind endolymphatic eye drops? One is there is obstruction of endolymphatic duct or sac. There can be hypoplasia of endolymphatic duct or sac. There's alteration of absorption of endolymph, alteration in production of endolymph, autoimmune insult, vascular origin, or viral etiology. So any of these can happen. So Meniere's disease as such can be classified into primary and secondary. Primary Meniere's disease is where the cause is unknown. So the most common is idiopathic. In this, yes, there are some theories or hypotheses postulated. So in primary Meniere's disease, there is increased production of endolymph, which is happening maybe because of allergy or sodium and water retention, autoimmune status, viral infection, or sympathetic activity, which is increased. All this can be seen in if there is hypothyroidism or hypopituitarism or hyperadrenalism or diabetes status or hyperlipoproteinemia, or there is decreased absorption of the endolymph. That may be because of the small size of the endolymphatic sac or duct, or if there is any obstruction of the endolymphatic sac or duct, if there is ischemia of endolymphatic sac, or inner ear trauma, maybe following a road traffic accident. So when do you say secondary Meniere's disease? Secondary Meniere's disease is you have a definite cause for the triad of symptoms like deafness, tinnitus, vertigo. So this can mimic Meniere's disease, but you have a definite etiological factor here. So that is seen in syphilis or otosclerosis. Otosclerosis, especially the cochlear variant of otosclerosis, you can see this. Cogan's syndrome, post-stapedectomy patients, yes, they may have, sometimes we may misdiagnose as having secondary Meniere's disease. Paget's disease, these are some of the other causes of secondary Meniere's disease. So classically in primary Meniere's disease, how do the patient come to you and how do you think that this patient may be having Meniere's? It is usually unilateral, common in males in the age group 30 to 60 years. This particular patients when they come with the sudden onset episodic vertigo lasting for 30 minutes to a day, associated with nausea, vomiting, and excessive sweating. So, in this particular condition, the vertigo is caused by loud, low frequency sound. So, that is called Tullius phenomena, characteristic of Meniere's disease. Another important clinical feature is sensorineural hearing loss, which is fluctuant. It improves after a vertigo attack and it is progressive. There is intolerance to loud sound due to recruitment, and some of the patients also complain of distortion of sound frequency, and that's called diplectrusis. Yes, patients also have tinnitus, which is low-pitched, roaring, non-pulsatile, continuous or intermittent type. It increases during vertigo attack. Oral fullness, again, is fluctuating and it is not relieved by swallowing. Yes, patients with Meniere's disease, they may be affected mentally, and mental health can be affected, and that can cause emotional upset or depression kind, and they may have anxiety or sometimes even agoraphobia. There are some variants of Meniere's disease. The most common Meniere's disease variant is Lermier's, which is reverse Meniere's. Here in Lermier's, there is deafness first, that is sensorineural hearing loss, followed by vertigo, and then there is improvement in hearing. Another variant is Tumarkin's sudden drop attack, where patient falls. There is loss of consciousness, but there is no vertigo. Other variants are oculovestibular response by Meyerhoff's, or there can be cochlear hydrops or vestibular hydrops. These are some of the variants which we should keep in mind. So once you see a patient in the outpatient department, next thing when you do a thorough E.N.T examination, you see that when you do an otoscopy, the tympanic membrane appears normal. And when you do elicit nystagmus, yes, definitely there will be irritative irritative nystagmus towards the disease side, and paralytic, that is slow component, that to the normal side, and then you see a recovery phase. There is always a false positive fistula sign seen in about 30% of the patients. It's false positive fistula because there is no fistula as such here. Okay, that's why it's false positive. This is called Hennebert's sign. Rinne test, when you do a tuning fork test, especially Rinne is positive, that is air conduction better than bone conduction. Weber's lateralized to the better rear, and absolute bone conduction test, when you do, is reduced in the diseased here. So what are the investigations you would like to do to confirm your diagnosis? So you have to do an audiological test, a vestibular test, and yes, radiological tests, autoimmunology, allergic tests, and general lab. So all these are done to know whether it is Meniere's or secondary Meniere's. So most common audiological investigation done is pure tone audiometry. There is a classical pattern which you observe, which we can observe in Meniere's disease. In the early stage, the low frequency sounds are affected. So in the first diagram or the first graphical representation, you can see that there is the low frequencies which are affected, and then as you go as the disease progresses, the mid frequency are affected, and then at a later stage the high frequencies are affected more. So you see a sloping graph. So this is a characteristic pattern of Meniere's disease when you do audiological tests. So early stage, when the patient comes, you have low frequencies affected. So low frequency sensorineural hearing loss, you can see around 500 hertz, 250 hertz, they are affected more. And as the recurrent episodes, the patient is coming to you regularly. So that time you see that when you repeat an audiogram, 1000, 2000 hertz frequencies are affected, and that remains plateau for some time. And In a chronic stage, high frequencies, especially 2000, 4000, 8000 hertz, these frequency sounds are affected. So you get a sloping graph. Other audiological tests which are done is speech audiometry. In that, speech discrimination score is about only 50 to 80%. Recruitment is present, and short increments is the sensitivity index is positive, which is more than 70% score, and tone decay is negative. So another important audiological investigation is electrocochleography. It is diagnostic as well as a prognostic test. So what exactly we see in electrocochleography is the ratio of summation potential to action potential. If the ratio of summation potential to action potential is more than 30%, and if you get a distorted microphonics, cochlear microphonics, then it is diagnostic of Meniere's disease. Yes, provided you have other associated symptoms, clinically you come across, sensory neural loss, and there is vertigo, all that when the patient is coming. And if you do electrocochleography, and if summation to action potential ratio is more than 30% with distorted microphonics, and you have to definitely think of primary Meniere's disease. So this is another important diagnostic tool which is very, very helpful for us. It's Glycerol test. So this is done to confirm the diagnosis and useful mainly again on prognosis. What we do here is we mix 1.5 ml glycerin, 1.5 ml per kg of glycerin in lime juice, and we give the patient. Before patient consumes this, you have to do an audiogram, and after taking glycerin with the lime, we will repeat the audiogram 2 hours later. So when you do so, you say Glycerol test is positive when there is improvement in 10 decibel or more at or more frequencies, or if there is speech discrimination improvement by 12% or more. That means the test is positive. That means, yes, the diagnosis in favor of Meniere's disease. So if the test is negative, do not reach the positive criteria, it does not mean that it is not Meniere's. But yes, if it is positive, definitely it is Meniere's. So what are the other investigations done? This is done, all these are done to exclude primary, or you think of secondary Meniere's disease. You have to do a full blood count with ESR, urea and electrolytes, RBS, FBS, fasting lipid profile, thyroid function test, VDRL, TPHA, immunological assay, antibody screening. All this has to be done. Another important test which we do is vestibular function test. You have a caloric test, you can do a caloric test, or if you have an electronystagmography, you can do that. Or if you have a video nystagmography, that is more ideal. It is more precise. The difference between electronystagmography and video nystagmography, if you ask me, yes, the technology is so advanced and you want to have a precise diagnosis, yes, better to go for video nystagmography. In electronystagmography, you have so many multiple electrodes which you have to to record ocular electrooculography. You have an active electrode, you have a ground electrode. All this has to be placed. Whereas in video nystagmography, you just have to wear the goggles, which are magnified lenses, and then you are video recording the movement of the eye, so you can precisely diagnose what is happening. Yes. So those were the investigations which you have to do to come into a conclusion. Now coming to the treatment, how you manage once you know that this particular patient is having Meniere's disease, how will you treat? So you can classify them into general measures, medical treatment, and surgical treatment. So depending upon the severity, depending upon what the patient wants, accordingly you can counsel the patient and treat. So again, acute attack of acute attacks of Meniere's disease, the treatment is different, and in chronic, again, the treatment differs. So overall, general measures, first thing is you have to reassure the patient, tell the patient to avoid coffee, tea, colas, chocolates, allergens, stress. Basically, yes, you have to tell them to meditate and do some yoga, and you have to tell the patient to quit smoking and alcohol, avoid heights, basically, avoid diving and flying, and these are some of the basic general measures which the patient has to follow. Yes, definitely patient should consume a low salt diet. You have to restrict the salt intake by 1.5 grams a day, and less fluids, maybe less than 1.5 liters a day, and increase the physical activity. So coming to the medical treatment, yes, in acute acute attacks, the treatment is different, and in chronic attack or chronic disease, the treatment is different. So you can give vestibular depressants like cinnarizine, diazepam, prochlorperazine, dimenhydrinate, cochlear vasodilators like beta-histine, carbogen, low molecular weight dextrin or histamine drip, diuretics like thiazide and triamterene, dexamethasone or IgG. This decreases autoimmunity. So steroids play a very important role if you're suspecting any autoimmune disease. Then you can, use hyperosmolar fluids, and that causes dehydration. Another treatment option available is hormone replacement therapy. So what do you do exactly when there is an acute attack of Meniere's? Yes, reassure the patient. If it's very severe, the patient is having severe vertigo and you can elicit nystagmus, patient is having nausea or vomiting, better to admit the patient and advise bed rest, head support, and start the patient on injection prochlorperazine or promethazine or injection diazepam. Yes, diazepam will actually, set the patient, and, they can rest better. So in such case, acute attacks, better to admit the patient and treat. Now there's another device called Meniette's device. It's a low pressure pulse generator. So the pressure pulses, they are transmitted to the round window via a grommet. So you have to do a myringotomy, insert a grommet. And when you use this device, there is a pressure which is generated, and through the grommet, this pressure is displaced, into the round window that will displace the endolymph, and there is relief of the endolymphatic hydrop. So vertigo, tinnitus, all those symptoms are relieved. So you have to use this for 5 minutes a day for 3 times a day. Now, if the medical treatment fails, and if the patient is really not happy with the medical treatment, and if the patient is willing for surgery, yes, you can proceed with some of the surgeries. And here, how do you plan whether this patient needs, what kind of surgery, what is best for the patient? How do you decide? So if the patient's, hearing as well as balance has to be preserved, or if the patient is having very minimal hearing loss and mild vertigo or moderate, in vertigo. So in that case, the patient will definitely want, you also as a surgeon want the hearing to be preserved. So in that case is what you do. The common procedure done is decompression surgery, wherein in that it is the endolymphatic sac decompression described by Portman in the year 1938. That is the most common procedure done nowadays, if at all patient is willing. Or you can do a sacculotomy by puncture of the foot plate, or you can do a cochlear duct piercing via round window. And another option here is when you want to do some surgical treatment, you have to see whether the hearing has to be preserved and only the balance has to be ablated. In that case, what you do is chemical labyrinthectomy or vestibular neurectomy. You can, identify the inferior vestibular nerve, and you can sacrifice that particular nerve supplying your utricle. Okay. So hearing ablation as well as balance ablation. This is considered when there is profound hearing loss and the labyrinth is completely, very chronic vertigo patients. There is no improvement in medical treatment at all. You can think of this when the labyrinth is, the ear is dead. So when you do a bithermal caloric test, or if you do a electronystagmography, if you think that there is no reaction at all, then you can go for total labyrinthectomy. So the most common decompression surgery performed is endolymphatic sac decompression by Portman, and then you can also go for endolymphatic sac shunting, or you can do a sacculotomy, fixed needle puncture of the foot plate, or Cody-Tax puncture of foot plate can be done. These are the two types or two different varieties described by Fix and Cody's. And then there is another option, cochlear duct piercing via round window. All these are very rarely done nowadays, as the patient are quite aware of the situation and they come to the hospital at an early stage, so they have better managed medically compared to these surgeries. So this is what is chemical labyrinthectomy. Here there is transtympanic drug injection. Here the hearing is preserved. The chemical what we use is vestibular toxic that is absorbed through the round window, and the most common drug we use is gentamicin or basically steroid. These are the two things which we use. So you can do an intratympanic drug installation by doing a meringotomy and bromide insertion, or you can go for drug installation via Silverstein microwave, or transtympanic drug perfusion. So you can just inject into the tympanic membrane. You can use a microscope or an endoscope, anesthetize the canal, and then you can directly inject, pierce the tympanic membrane, and then whatever drug is, perfused into the middle ear, that is absorbed by the round window. Okay. Gentamicin is basically a vestibular toxic. So that's how, chemical labyrinthectomy is performed. Coming to some of the surgeries which are, done is vestibular neurectomy via middle cranial fossa approach, or you can destruct the vestibule via round window or lateral semicircular canal using a cryoprobe or an ultrasound probe. Yes, when both cochlea as well as vestibular functions are destroyed, if the patient is having severe deafness, you have two options. See, hearing is already gone, so there's no point keeping vestibular or cochlear nerve there. So you section the eighth nerve. Or you can do a transmastoid total labyrinthectomy, where it's a radical procedure where you completely remove, whole of the labyrinth. So the indications for total labyrinthectomy nowadays is comparatively less for the Meniere's and more for translabyrinthine approach to the cerebellopontine angle tumors. So the indications in the recent days has been changed. Rather than doing it for Meniere's, this is most commonly done for as a translabyrinthine approach to cerebellopontine angle tumors like acoustic neuroma or meningioma or whatever. So here transmastoid cortical mastoidectomy is done, and then you see that the vestibule as well as the semicircular canals are exposed. You have to drill. It's not very easy to do a labyrinthectomy. This is one of the most dense bone in the human body. So when you are trying to drill, it definitely takes time, and it's very you have to do the surgery very meticulously. So it takes time. definitely time consuming surgery. So you have to elaborate, delineate properly, drill everything, expose. Then you see in the second diagram, the vestibule ampullae open to show the neuroepithelium. And in the third picture, you can see even the neuroepithelium is destroyed. This is what is done in total labyrinthectomy. So no neuroepithelium, no stimulation, no action potential, no vertigo. In labyrinth, when you're sectioning the eighth cranial nerve, is again, when the nerve is not there, there is no, transmission, or, there is no signal going to the brain. So this is about total labyrinthectomy. Now coming to the treatment ladder, just in brief, summarizing the management or the treatment aspects of meniscus. Again, the treatment is individualized. So some patient may come in a mild form, some may come in a moderate or in the severe form, some may come, acute stage, or sometimes the patient come in a chronic stage. So it's like individualized. You don't have to follow the same thing. Yes, the general measures are the same for everyone. Sometimes you may also have to do a vestibular rehabilitation. Exercises have to be taught to the patient. That is also one of the general measures. For the vertigo, the patient may have some relief when you do so. So yes, general measures like salt restriction, definitely fluid restriction. Yes, you have to tell them to avoid alcohol and smoking and coffee or tea or hot chocolate, whatever. And yes, you have to treat the patient conservatively with medical treatment like cinnarizine or anti-vertigo, non-sedative drugs. Then you can give cochlear vasodilators like beta-histine. Yes, if patients are affordable, yeah, you can go for Meniette device if they are comfortable with, or if they are not willing for surgery, you can do all this. If the patient is willing, these are some of the destructive procedures which can be done depending upon whether the hearing is preserved, you want to preserve hearing or not, or if both hearing is gone as well as labyrinth is dead, then there is no point keeping, so you can just go for total labyrinthectomy. So this is it's a ladder. You have to think what is best for the patient for that particular time. So with this, I end my session. Let us come again with some other new interesting topic. Thank you.